Good afternoon. It's now 2:30, and we will reconvene the meeting to begin the next session on influenza vaccines. Dr. Jamie Lair, chair of the Influenza Work Group, will provide an introduction and overview of today's session. Dr. Lair?
Thank you, Dr. Wharton. So I'm going to be giving an introduction to the Influenza Work Group. Next slide. I'd like to thank all the hard workers, including the ACIP members, Dr. Camille Cotton, and especially the CDC lead, Dr. Lisa Groskopf, who herds cats, or at least doctors and staff on the committee. Next slide. And all the CDC participants have also been very helpful with moving forward. Next slide. There are three main topics that we're going to present today. The first is giving the annual review of vaccine effectiveness, and we want to give the preliminary estimates. This is going to be for both adults and children, for both outpatient visits and hospitalizations. And Dr. Frutos and Dr. Zhu are going to be giving interim estimates of the influenza vaccine effectiveness. Next slide. The second topic is the LAIV vaccine in the setting of asthma and wheezing. As you know, right now the LAIV vaccine is not recommended for children ages 2 through 4 with a history of asthma or wheezing, and it's considered a precaution for children 5 years and older, and that's because a review of the safety showed that there is some possible higher risk of wheezing. There's going to be a review safety moving forward, but today we're going to be hearing an update on the safety of LAIV in children with asthma. Next slide. And you've all heard about influenza B Yamagata. There's been no confirmed detection of this virus lineage since March 2020, and thus the World Health Organization and the FDA VRBPAC committee have recommended exclusion of this lineage from influenza vaccines as soon as possible. And Dr. Groskopf will be giving us an update on the plans for this. Next slide. Thank you very much, and I'll turn it back to Dr. Wharton.
Thank you, Dr. Lair. Our next presenter is Dr. Frutos from the Influenza Division.
Good afternoon. I will be presenting the CDC's interim estimates of 2023-2024 seasonal influenza vaccine effectiveness. This year, 4 networks contributed to the interim estimates of vaccine effectiveness against laboratory-confirmed influenza for children and adolescents and adults in the outpatient and inpatient settings. The CDC influenza vaccine effectiveness networks that are included in this presentation are the Investigating Respiratory Viruses in the Acutely Ill, or IV, the New Vaccine Surveillance Network, or NVSN, the U.S. Flu Vaccine Effectiveness Network, or US Flu VE, and the Virtual SARS-CoV-2 Influenza and Other Respiratory Viruses Network, or VISION. This graphic shows the ages and settings included for each network. Across the networks, all ages across multiple settings are included in the interim estimates this year. I will now go through each part to show how each network contributes to the interim VE estimates. Starting with children and adolescents, NVSN includes patients from outpatient clinics, emergency department and urgent cares, and those admitted to the hospital. US Flu VE includes patients from outpatient clinics, emergency departments, and urgent cares for children and adolescents. VISION includes patients from emergency departments and urgent cares and those admitted to the hospital. Now moving to adults. IV includes patients admitted to the hospital. US Flu VE includes adult patients from outpatient clinics, emergency departments, and urgent cares. Lastly, VISION includes adult patients from emergency departments, urgent cares, and those admitted to the hospital. Again, these networks together include all ages across a variety of settings. Moving forward, we will refer to outpatient clinics, emergency departments, and urgent cares together as the outpatient setting. This map shows the geographic representation of the different networks, as these networks include patients from 22 different states. The methods used by each network to estimate influenza VE are very similar. All enrollees across all networks sought medical care for acute respiratory illness. Patients are included from fall 2023 to early 2024. Each network uses a test-negative design which compares the vaccination odds among case patients with influenza confirmed by molecular assay versus control patients testing negative for influenza and SARS-CoV-2. Vaccination status was determined as receipt of any of the 2023-2024 seasonal influenza vaccines according to medical records, immunization registries, claims data, and/or self-report. Vaccine effectiveness is calculated as 1 minus the adjusted odds ratio times 100%. Each of the networks adjusted for geographic region, age, and calendar time of illness. IV, US flu VE, and Vision also adjusted for sex and race and ethnicity. Additionally, US flu VE adjusted for days between illness onset and enrollment and self-reported general health status. VE estimates were calculated for influenza A subtypes A H1N1 PDM09 and A H3N2 when possible. Influenza A subtype estimates were not calculated for Vision because of limited subtype data. VE was not estimated for some age groups and settings when sample size was small or when models did not converge. I'll now present the VE estimates stratified by age, starting with children and adolescents. This table shows the number of influenza-positive cases and influenza-negative controls, as well as the prevalence of vaccination among both across network and setting. I want to highlight the prevalence of vaccination among controls, which varies from 25 to 41% across settings. These same controls are included as part of each of the following pediatric VE estimates. Because we have many estimates from the 4 networks, we will now show the VE estimates in a graphic. By way of orientation, setting is on the y-axis with outpatient on the top and inpatient on the bottom, with VE along the x-axis. Pediatric VE against any influenza range from 59 to 67% in outpatient settings and 52 to 61% in the inpatient setting. VE estimates were consistent across networks. Pediatric VE against influenza A ranged from 46 to 59% in outpatient settings and 46 to 56% in the inpatient setting. Pediatric VE against influenza A H1N1 PDM09 ranged from 54 to 61% in outpatient settings and was 60% in the inpatient setting. Pediatric VE against influenza A H3N2 was 55% in outpatient settings and was not estimated in the inpatient setting. Pediatric VE against influenza B ranged from 64 to 89% in outpatient settings and was not estimated in the inpatient setting. Now I will present the VE results for adults aged 18 years and older. Here's the table of included influenza-positive cases and influenza-negative controls. We see that the vaccination prevalence ranges from 39 to 52% among test-negative controls across settings. Adult VE against any influenza ranged from 33 to 49% in outpatient settings and 41 to 44% in the inpatient setting. Adult VE against influenza A ranged from 27 to 46% in outpatient settings and 40 to 42% in the inpatient setting. Adult VE against influenza A H1N1 PDM09 was 25% in outpatient settings and 50% in the inpatient setting. Adult VE against influenza A H3N2 was 54% in the outpatient setting and was not estimated in the inpatient setting. Adult VE against influenza B was 78% in outpatient settings in 2 networks and was 60% in the inpatient setting. We again see consistent results across networks. Now I will show the results for adults aged 65 years and older. Among adults aged 65 and older, the prevalence of vaccination among test-negative controls ranged from 48 to 68% across settings. Amongst adults aged 65 and older, VE against any influenza ranged from 41 to 51% in outpatient settings and was 42% in 2 networks in the inpatient setting. We again see that the results are consistent across networks. Among adults aged 65 and older, VE against influenza A ranged from 40 to 52% in outpatient settings and 42 to 47% in the inpatient setting. VE against influenza B for adults aged 65 and older was 69% in outpatient settings and was not estimated in the inpatient setting. The estimates presented show that vaccination with the 2023-2024 influenza vaccine reduced the risk for medically attended influenza outpatient visits and hospitalizations among children and adolescents and among adults across 22 U.S. states. Vaccination was effective against both influenza A, mostly A H1N1 PDM09, and B lineage Victoria viruses that have circulated this season. We saw that the VE estimates were consistent across networks. I'd like to thank our many collaborators from CDC, IV, MVSN, US Flu VE, and Vision, whose work contributed to the estimates presented in this presentation. Thank you for your time.
Thank you very much. We're going to go ahead and do our next presentation, and then we'll take questions after both of them. So if you've got questions on this one, make note of them so you have them in mind. Our next presentation is Dr. Zhu on interim influenza vaccine effectiveness against laboratory-confirmed influenza in California.
Hello. Understanding influenza vaccine effectiveness, or VE, can be a multifaceted approach that leverages diverse data sources, populations, and care settings to investigate VE against different outcomes. New public health data reporting requirements in California offer an opportunity to calculate VE against laboratory-confirmed influenza, resulting in estimates that are additional to and available ahead of traditional platforms. As of January 1st, 2023, all influenza vaccination records became reportable to CARE, the California Immunization Registry. Positive influenza results have been reportable in California since October of 2019, and as of June 15th of 2023, negative influenza results became reportable to CalReady, the state electronic communicable disease reporting system, which includes lab reporting. We leveraged influenza laboratory results matched to immunization registry data to calculate early VE estimates against laboratory-confirmed influenza in California during the 2023 to 2024 influenza season. Compared to traditional CDC VE platforms, this analysis utilizes existing influenza results and immunization registry data for a large state. Estimates are available in December or earlier. And please note that estimates from this analysis reflect VE against laboratory-confirmed influenza using nucleic acid amplification tests and include persons tested for influenza from diverse care settings and symptom severity levels. This contrasts with the more specific outcomes that CDC measures that have accompanying illness enrollment criteria. We calculated VE using a case control design where persons testing positive for influenza are case patients and persons testing negative for influenza are control patients. Persons included in the analysis were all California residents aged 6 months and older with molecular tests for influenza captured by the state electronic laboratory reporting system. Most influenza testing performed at clinical and commercial laboratories that report influenza A and B test results do not perform subtyping. Dates of analysis were October 1st, 2023 through January 31st, 2024. Participants were considered vaccinated if there was at least one dose of seasonal influenza vaccine documented in care 14 days or more before testing. Records with multiple test results were deduplicated. The earliest positive test result was selected for persons with both positive and negative results. Results from laboratories that exceeded a 50% positivity threshold were excluded due to suspected underreporting of negative results and/or known misclassification of negative results as positives. Adjusted VE was calculated as 1 minus the adjusted odds ratio times 100%. We used mixed effects logistic regression, adjusting for age as a natural cubic spline, race and ethnicity as fixed effects, and testing week and county of residence as our 2 random effects. In California, overall influenza virus positivity last week was 6.5% and has declined from prior weeks. Based on subtyping at public health laboratories in California, this is a predominantly H1 season so far. 82% of samples have been influenza A, and 75% of those have been H1 this season. There were 678,422 individuals included in this analysis, including 77,501 influenza positive cases, which is around 11% positivity, and 600,921 influenza negative control patients. Median age was 31 years for case patients and 44 years for control patients. There was a similar breakdown of race and ethnicity for the case and control patients. Overall, 28% of individuals were vaccinated. 18% of case patients were vaccinated overall versus 29% of controls. Going month by month, vaccination increased from 13% during the month of October all the way to 34% during January. And a similar lower vaccination rate was seen in case versus control patients throughout all time periods. Adjusted VE against laboratory-confirmed influenza overall was 45%. VE declined with increasing age and was highest at 56% in children aged 18 years and younger, 48% in adults aged 18 to 49, 36% in adults aged 50 to 64, and lowest at 30% in adults aged 65 years and older. VE against influenza A was lower than overall influenza VE, but still protective at 42%. Over 90% of cases in this analysis were influenza A, which is consistent with both California and national trends. Age-specific VE declined with increasing age and was lowest for adults age 65 and older at 29%. VE for influenza B was high at 76%, and estimates were generally comparable across younger age groups, ranging from 75 to 79% for persons 6 months to 49 years of age. Similar to influenza A, estimates were lower among adults 50 years and older. Less than 10% of cases were flu B. Finally, these are the comparisons of VE over time, calculated using cumulative data through the specified dates. As you can see, we had an adjusted VE estimate of 46% on October 31st using 1 month of early season data. Over time, this estimate remained relatively stable, though with narrower confidence intervals as testing volume for influenza increased. There are many limitations to this approach. First, this is the initial year of mandatory reporting of both vaccination records and all influenza test results, which may lead to incomplete documentation and reporting. Second, we could not assess partial or full vaccination status for children aged less than 9 years of age. Based on ACIP recommendations, some children required 2 vaccine doses in the first influenza season when they received vaccines. We were thus unable to confirm partial versus full vaccination status due to lack of prior season vaccination data. Third, influenza result reporting in California lacks information on symptoms, and this could lead to biases if control patients were not equally likely to get tested compared to case patients based on presence or severity of symptoms. We also do not know the test setting or final outcome status of persons in this analysis. This meant that VE against illness, hospitalization, and death could not be considered. Fourth, because of the limited geographic scope and potential variability in local circulating influenza viruses, these results may not be generalizable across the US. Fifth, subtype information was not available for positive influenza results, so VE for influenza subtypes could not be calculated. And finally, we did not control for other confounders such as healthcare-seeking behavior and pre-existing conditions. Current influenza vaccines provide protection against laboratory-confirmed influenza in persons 6 months and older. VE was higher for influenza B and younger persons, but vaccination still provided protection for all age groups against both influenza A and B. Mandatory public health data can be leveraged to calculate timely in-season influenza vaccine effectiveness as an additional estimate supporting existing public health influenza prevention efforts. Earlier estimates can inform public health action and messaging for additional prevention measures prior to the peak of influenza infections, and could be especially informative for healthcare settings that may need to reallocate resources to prepare for increased hospital capacity. Thank you so much to California local health departments, CDPH Division of Communicable Disease Control, and partners at CDC and CIRD. Thank you.
Thank you very much for that presentation. Both of these presentations are now open for questions or discussion. It's great seeing these in-season estimates. It's so much more information than we used to have. Oh, yes. Dr. Long.
I wonder if the vaccine work group had discussions about the overall program and looking a little at the future of influenza vaccines. It seems like, I'm sure you recognized, a lot of effort and a lot of money for seemingly diminished or diminishing effectiveness against the most severe forms of influenza. And is it possible that we ought to time out of, in the absence of a pandemic, a new pandemic, of annual immunization? I understand that we're not going to solve this here, and I don't mean that the vaccines are ineffective, but there seems to be diminishing returns for annual influenza immunization. I wonder if Dr. Lair wants to say anything. Did the work group discuss this at all?
I'd like to clarify, are you talking about diminishing returns over time, or are you talking about, in general, the inpatient effectiveness isn't as good as the outpatient effectiveness?
I'm talking about vaccine fatigue in a different way than people getting tired of it, but your immune system getting tired of seeing these antigens over and over again, be it natural or be it vaccine.
That hasn't come up that I'm aware of. Dr. Grosskopf, do you have any comments?
Make a general comment, but I welcome my colleagues who, from the VE group who are here, who are far better than I am. If what we're getting into here is repeat vaccination and potential detriment, is that what you meant, Dr. Long? Repeated vaccination across
exactly
seasons?
what you said. Okay. Yes, detriment of repeated vaccinations.
It is a topic of a good amount of research and a couple of systematic reviews at this point. It's a little difficult to tease out the results, mainly because they're not consistent necessarily. The one thing that does seem to arise consistently from these things is that in general, you are better off if you got vaccinated than if you didn't in any given season. While some studies might demonstrate that you might be slightly worse off if you'd gotten vaccinated previously. It's also very difficult to know how to translate that kind of data into a policy recommendation, because exactly what would you how would you try to structure a schedule? It is something we're probably going to be discussing more going forward, but at this point we haven't had any recent work group discussion about it. And I'd welcome anybody from my group to comment. No? Okay. Thank you.
And could we ask our FDA colleague if there are any new biologic license applications for any novel influenza vaccines?
It's a good question, but I'm not at liberty to discuss those submissions.
Well, it certainly is an area where there's been a lot of research in recent years. Dr. Beigel, was there anything you'd want to add to that?
The NIH and NIAID have invested heavily on both better seasonal influenza vaccines and broadly protective influenza vaccines. So there's a lot in the R&D space. It's just not quite in the clinical availability space.
Any other questions or comments? Well, if not, we will move on to the next speaker, which is Dr. Creech from Vanderbilt, who will be talking about the safety of LAIV4 in children with asthma. Dr. Creech?
Thanks for having me today. I appreciate the opportunity to share a little bit about what we're doing. And to Dr. Long's point, we do have a couple of different products that we can use in the vaccine space, and whether some are better than others is the subject of a lot of interrogation. One of the places that we wanted to lean into that with our CDC CISA project and the Immunization Safety Office was to reassess this idea of safety in those individuals who have underlying asthma. So I'm going to talk a little bit about this study, which is the safety of LAIV in children with asthma. And on the next slide, I'll give our typical disclaimers, which deal with that these findings and conclusions are those of me and don't represent the official position of the CDC. If anything is mentioned that is a company name or a product, that's really just for ID purposes only. This study was supported by the CDC Immunization Safety Assessment Project, and then I list a few disclaimers there of folks that I've worked with, provide grant funding or consultation funding for. None of those are related to influenza vaccines or to asthma. On the next slide, I would just highlight the study teams and thank them for their participation in this work. First and foremost, this study was conducted at our site at Vanderbilt University Medical Center here in Nashville, Tennessee, at Duke University, at Cincinnati Children's, and then led with our colleagues at CDC. And so one of the strengths, I think, of the study that I'm going to share with you is that it's a multi-center study done over a couple of seasons of influenza, so we think the generalizability of this might be fairly high. For those who want to see the bottom line up front, that's shown on the next slide. The paper was published in Pediatrics not too long ago, and the bottom line up front is that in a study of 142 children, those are analyzable children with persistent asthma, LAIV4 was not associated with increased frequency of either asthma exacerbations or increase in asthma-related symptoms or a decrease in peak expiratory flow rate in the 6 weeks following immunization. Now, this study has to be contextualized with what we've known historically, and I'll just highlight 3 studies on the next slide that give us a sense of where this field has gone. And the first is a study from our colleagues at Northern California Kaiser looking at asthma exacerbations among children with asthma who received live attenuated vaccine. And one of the things I think that's important to recognize is that in that study, 85% of the cohort had received IIV, about 15% had received LAIV, and there was really not a large portion of children who got LAIV who had severe asthma. This was sort of a standard of care. Let's look at those who ended up getting LAIV, but it was not associated with asthma exacerbation. In the second study, done more broadly through the VSD, LAIV use was considered safe in children and adults with asthma. But again, in this data set that's extraordinarily large, less than 1% had received LAIV. So it may be difficult to extrapolate what that would look like in a prospective randomized fashion. And the final study from the UK, from Paul Turner and his colleagues, looked at the safety of LAIV in children specifically with moderate to severe asthma. And this was a study in which they looked at exacerbations for 28 days following vaccination, but there really wasn't an IIV comparison, but was just an overall assessment of safety. So in all of these studies, children with asthma who received LAIV were not found to have a higher incidence of lower respiratory events or wheezing. But we thought there was still more that could be done to assess whether or not this was safe in those with moderate to severe asthma. So let me show you the study design on the next slide. We randomized 151 individuals. A handful in both groups were lost to follow-up. There was nothing unique about those, and so that did not affect the analysis. Half of those approximately received LAIV4. Half of those received IIV4. You'll see those listed there. These were 5 to 17-year-old children who had persistent asthma. And I think it's really important to recognize, and I'll show you a definition in a moment, but these were children who did not have mild intermittent asthma or a remote history of asthma, but who were currently being managed with persistent asthma, with a particular focus on those with moderate to severe disease. Day 1 is an enrollment. Day 8 was a reminder to complete a diary card or a memory aid for reactogenicity. On day 15, we did formal symptom assessment, which involved inhaler use, as well as scoring systems for asthma severity or asthma control. On day 29, another reminder. And then on day 43, another symptom assessment that was one of our main outcomes. So to speak of that, our primary objective and our definitions on the next slide were to compare the proportion of participants who experienced an asthma exacerbation during the 6 weeks after LAIV4 versus IIV4. And the scientific hypothesis here was that LAIV4 would be non-inferior to IIV, but the null hypothesis expressed statistically is that the proportion of children who experienced an asthma exacerbation in the LAIV4 group would be more than 10% higher than the proportion in the IIV group. So that's the null hypothesis that we're hoping to reject if our scientific hypothesis is true. Here are the definitions. Persistent asthma was a provider diagnosis of asthma in addition to prescription of a long-acting controller medication, and that distinguishes it from previous studies that looked at either intermittent asthma or a remote history of asthma. And then we defined an asthma exacerbation as an acute episode of progressively worsening shortness of breath, cough, wheezing, chest tightness, or respiratory distress for which the patient sought medical attention, or because of the commonplace phenomenon of someone calling in and saying, I'm wheezing, the provider diagnosis of an asthma exacerbation with a new prescription for systemic corticosteroids. That's how we defined the asthma exacerbations. On the next slide, I'll just highlight a few relevant exclusion criteria. If they were sick within a few days of the enrollment, we temporarily delayed their vaccination. If they had had recent receipt of an inactivated or live vaccine, we took that into account and either delayed or waited to enroll them. And if they had any planned receipt of a vaccine within 42 days of vaccination, the purpose of which was not to cloud any assessment with additional interventions. Children who had immunosuppression, specifically, we wanted to make sure they weren't on prednisone or an equivalent for more than 14 days in the previous month, in part because we knew that that would affect the underlying inflammatory nature of the lungs and might, again, cloud the assessments. Children who had a life-threatening exacerbation in the previous 2 years or any exacerbation in the month prior to enrollment were excluded. The use of influenza-specific antivirals within 2 days of enrollment were excluded because of the need for an LAIV take, and then those that were currently receiving aspirin were excluded. On the next slide, I will show you additional eligibility issues for completeness in that postmenarchal females had urine or serum pregnancy testing prior to enrollment. And then those children who were on the younger age of our cohort who required 2 doses of vaccine based upon ACIP recommendations, their enrollment into our study could occur after either the first or the second dose. But if they got it after the first dose, then the study staff instructed the family to delay the second vaccine until study follow-up was completed at 6 weeks, which meant they delayed it by about 2 weeks. And the only reason they wouldn't have done that is if there was a lot of disease activity in the community, and we didn't have to trigger that in the study. On the next slide, I'll show you table 1, which are the baseline characteristics by study arm. And I'll go ahead and highlight a couple of things with the next slide, which is the second column is LAIV4. You'll see 79 individuals in the red box. IIV4 is in the third column with an N of 72. We had a majority of individuals have moderate or severe asthma in each group. You'll see the numbers listed there. We compared their baseline asthma control scores. Those were not different between the groups. I show you the age groups there. This was largely a 5 to 11 year group, but about a quarter of the group was in the 12 to 17 range. There were numerically more males than females, but that was not a statistically significant difference. You'll see that ethnicity, this was largely a non-Hispanic, non-Latino group. But when we look at race, you'll see that about 1/3 of the group identified as Black, which we think helps the generalizability of these data in that we recognize that those that are Black or of African-American origin, that they have a higher likelihood of asthma in many of our populations. So we were excited to have a more representative population than we sometimes see in clinical studies. And then you'll see their BMIs were similar between groups. On the next slide, I'll show you table 2, which are the asthma exacerbation numbers. We assumed for biostatistical assessment that about 10 to 12% of children would experience an exacerbation in the 6 weeks that followed. So let me start with the 2 weeks at the top. In the 14 days following vaccine, we saw 3 exacerbations among LAIV4 recipients and 4 in the IIV4 recipients. So that is 3.9% versus 5.7% with a p-value of 0.74. In the 6 weeks following vaccine, there were 8 exacerbations in the LAIV group and 10 in the IIV group. That works out to 10.8% versus 14.7%. Again, a p-value of 0.71. And in the table, I show you that broken down by those who had mild disease, where in the 14 days after exacerbation, there were no, or 14 days after vaccination, there were no exacerbations. And then you can see those that were moderate or severe, and then all participants added together. So given that the upper bound for non-inferiority was 10%, meaning we didn't want to see it be 10% worse than the standard, a difference in proportion of 3.9%, that's that 14.7% minus 10.8%, that means we can reject the null hypothesis because that 90% confidence interval ranges from negative 0.15 to 0.07. So I think we can reject the null hypothesis safely that LAIV4 is inferior to IIV4, and that means we reach our scientific hypothesis that it is non-inferior. Now, on the next slide, I'm going to highlight a couple of things related to the granularity of those exacerbations, because I think one potential criticism could be that an exacerbation represents maybe the tip of the iceberg, and that there might be an increase in symptomatology that in the right patient at the right time might lead to increased symptomatology that then could lead to an exacerbation. So if we look at the asthma symptoms within 14 days, we look at the percentage on the x-axis or on the y-axis, we look at symptoms on the y-axis is percentage, x-axis is symptoms. Blue is LAIV4, red is IIV4. I think what you can appreciate is that in each one of these, there were no significant differences seen when comparing either across age groups, study site, or asthma severity. But what I think you can appreciate is that nighttime awakening was less in the LAIV4 group. Cough was very similar. Wheezing appeared less. Chest tightness appeared less. Unscheduled albuterol use was similar, not statistically significantly different. Same way with peak flow. So even as we look at a more granular aspect of these data, which are the symptoms, those also did not show that LAIV4 was associated with increased symptomatology. When we look next at the side effect profile of either LAIV4 or IIV4, we begin to see some differences between the two groups. And this is on the next slide, where myalgia and sore throat were seen more frequently in those who received IIV4. And in the red boxes, you'll see sore throat, where in the LAIV4 group, 54% reported no sore throat, 19% had mild sore throat, 3% had moderate sore throat. If you compare that to the IIV4 group, 18% had mild sore throat, 6% with moderate, and 5% with severe sore throat. Now, I'm not suggesting, again, I'm not suggesting that IIV4 is a common cause of sore throat, but highlighting the fact that even those symptoms that aren't necessarily referable to influenza or to asthma, that we do see some upper respiratory symptomatology even after IIV4, like sore throat. When we look at myalgia, it was more frequently encountered in the IIV4 group. Maybe we could hypothesize that that's due to a more systemic response. I don't know, and we can't speak to that in our study. So on the next slide, I'll just highlight some strengths and what I think are limitations of the study. This was a multi-center prospective randomized and controlled study. It was enriched for children, not just only with persistent asthma, but those with moderate to severe asthma. It captured the symptoms in addition to exacerbations and medical utilization, which is something we can do in prospective studies. It captured reactogenicity data, which I think are important, and then enrolled over 2 influenza seasons, somewhat out of necessity because this began shortly after the pauses in LAIV4 administration that we had in the US. But we think that actually increases generalizability. And then from a limitation standpoint, we enrolled fewer participants than originally intended, but posterior power calculations revealed adequate power at 79% to detect differences between these groups. And then you could say, and our strengths are our limitations too, we enrolled over 2 influenza seasons, which led to slightly different products, but not so much that we would expect fundamental differences. And when we look at the data over those 2 years, we don't see differences that are based on the season in which they were enrolled. So on the next slide, I'll just leave you with 3 takeaways. LAIV4 was not associated with increased asthma symptoms or exacerbations in the 14 or 42 days following immunization. Rates of reactogenicity were similar between the 2 groups, although myalgia and sore throat were more common in the IIV arm. And then I would just highlight that LAIV4 may be a suitable option for children that are 5 years of age and older who have asthma, including those with moderate to severe asthma. So I'll finish with recognizing the team again, in particular our team at CDC, Karen Broder, Teresa Harrington, Frank DiStefano, as he was still there, Lisa Grosskopf, Owita Suzanne, and Patricia Wody, as well as all of our sites at Duke and at Cincinnati and here at Vanderbilt. And I'd be delighted to take any questions that you might have.
Thank you, Dr. Creech. Are there any questions? Dr. Snaes.
Thank you so much for that presentation. I was just curious if there were any disparities by race in those experiencing exacerbations and or asthma symptoms.
Yeah, it's a great question. Yeah, it's a great question. We do not have a sufficient number of exacerbations overall to be able to say with any degree of certainty whether there are racial, ethnic, or other disparities that drove that. As it relates to symptoms, there were certainly no statistically significant differences, and I don't recall any numerical imbalances in those groups. But I'll take that back just to make sure of that. But no, we didn't see anything that really drove that in the secondary analyses.
Dr. Brooks.
Yeah, thank you for this information. I would like theoretically for maybe other studies to show this, and it'd be nice to know we can give LAIV to our children with persistent asthma. Can you just comment on your p-values in general?
I can. I'm happy to do that. I think this, from my standpoint, with the necessary disclaimers that I'm speaking as one person, I think this really is one of the final pieces to the puzzle, in my opinion, of whether those who have asthma can receive LAIV4. We have retrospective data in large data sets. We have other prospective studies like the UK study from Paul Turner. We have this prospective study. I'm not sure what the study design would need to be unless it's just far more patients to be able to provide that confidence. So we have 80% power, 79% power to detect a difference, and that would be a standard acceptable a degree of power, because one of the first things we want to say is that we don't want to say there's no difference when indeed a difference exists. So that's the first one. Number 2 is the directionality of the effect. Recall that the directionality of the effect was it was a 4% reduction in the likelihood of exacerbation. That's the point estimate. And we look at the 90% confidence interval, which would correspond to a p-value of 0.05. We fall well within the bounds that we set a priori for confidence that we met that non-inferiority margin. So while I can't sit here and say with certainty that LAIV4 is better than IIV4 in asthma exacerbation frequency, I can say with biostatistical confidence and consistent with previous papers, some of which have 6 million records, that LAIV4 does not appear to be associated with asthma exacerbations in those in that 5 to 17-year-old range who have asthma.
Thank you.
Dr. Daly and then Dr. Kimberlin.
Thanks so much for this, Dr. Creech. A comment and then a question. The comment is that when this has been looked at in safety systems, there's a challenge if LIAV is preferentially given to kids who really have very mild asthma, or to someone who the provider thinks, this is not really asthma. So it makes it much harder from an observational standpoint in the safety context, even though those results generally were reassuring. My question is just a really simple one, Dr. Creech, which is, can you remind us what the language is around the precaution for LAIV use in existing recommendations or package inserts? Thanks.
Yeah, that's a great question that I did not prep for. My memory of it that I'm certain that Dr. Grosskopf could perfect is that currently the administration of LAIV4 is considered, well, the way I guess it would be worded is that asthma is considered a precaution in the use of LAIV4. But I don't know that it's much more dramatic than that. But I would love to defer to Lisa on that.
Hi. So there are two levels. For people with asthma that are 5 years and older, it's a precaution. And then the wording for the 2 through 4-year-olds, and we don't speak below 2 years because LAIV is not licensed under 2 years of age. It's a precaution, and it's a little bit broader because difficult to diagnose asthma in very young children. But children aged 2 through 4 years who have received a diagnosis of asthma, or whose parents or caregivers report that they've been told their child has had wheezing or asthma in the last 12 months, or whose medical record indicates a wheezing episode has occurred during the preceding 12 months, which is a little complicated. And some of that language originates from much older package inserts for LAIV. We are working on a systematic review of this topic now, and some of the difficulties with that are what you might imagine given the difficulties with diagnosis of asthma in very young age groups. So it does make the outcome definitions a little challenging.
Yeah, and Lisa, thank you for that. I would just add that this is one of the reasons why we chose this particular age group, is that the diagnosis of asthma in children 5 years of age and older is much cleaner. Especially to Matt, to your previous point about previous studies maybe having a bias towards either intermittent or remote or whatever kind of asthma it was in younger folks, and there was a preferential use of IIV in anyone who had, quote, real asthma. I think the strength of this is that we had every single person in this study was on a long-acting controller medication for their asthma. And it implies a chronicity and a certain level of persistence. And we enriched for those with moderate to severe asthma. And as a result, we had exacerbation rates that were in those double digits like we anticipated. So I think that's maybe one of the strengths. So despite the reasonably powered but modest sample size, I think that's why we still see confident results that we can reject the null hypothesis here.
Before we move on to Dr. Kimberlin, Dr. Kasler, do you want to say something about what's in the current package insert?
So in the package insert in section 5 is where we put the warnings and precautions. And there are 2 sections in there that speak to wheezing. One is the risk of hospitalization and wheezing in children younger than 24 months of age. I think we'll take that off the table. But as it relates to asthma, recurrent wheezing, and active wheezing, children younger than 5 years of age with recurrent wheezing and persons of any age with asthma may be at increased risk of wheezing following administration of Flu/Mist quadrivalent. Flu/Mist quadrivalent has not been studied in persons with severe asthma or active wheezing.
Thank you. Dr. Kimberlin?
David Kimberlin, AAP Red Book, and really my question, now I'm not quite sure who to ask it of. It was very much in line with this past couple of minutes of discussion. How will these data get before the FDA for consideration of modification of the package insert, or perhaps a CDC recommendation? I'm not sure if that goes to Dr. Creech now, or if it goes to Dr. Kaslow or Dr. Grosskopf.
Dr. Grosskopf, do you want to just expand a little bit on how the work group is approaching this?
So with the work group, we've developed a protocol for a systematic review, which we've begun, and that, excuse me, that will include data going basically as far back as we can go in terms of studies of LAIV. It is focused on safety only. We're not examining any efficacy outcomes in that review. So from the point of view of ACIP, that's the approach we're taking.
Dr. Long.
Dr. Creech, thank you so much. Can you tell us if there was any clustering of the two objective or the two last things that were a little higher in the LAIV group, which were unscheduled use of inhalers and the pulmonary function? Was there any clustering in one group versus another?
Great question. No, not that we could ascertain. Again, those numbers are reasonable, but they're not enormous in those groups. But there were certainly those who had a peak flow decrease as well as unscheduled albuterol use, but there was not such a clustering that they were maybe collinear together. The other thing I would just make mention of is that, especially in some of our younger children, we went back and forth during study design about whether peak flow was an accurate representation of actual pulmonary function in some ways. And many of our pulmonologists urged us that, you know, it is a number that we can chase, but it's not necessarily a reliable number, especially in younger children who haven't yet figured out how to give a maximal effort in a way that is reliable and consistent. So while it is maybe one of the more objective metrics of asthma symptoms that we used, I don't know that I would state with confidence that that represents reality.
Dr. Beigel.
Buddy, do you think your study population reflects the general population with asthma? I could see an argument that children that participate in this and the families that facilitate children participating in the study actually are plugged into the system better, might receive more standard care than general population.
Well, John, yeah, I think you're spot on. What do these individuals, what are they like? Well, they're folks who have doctors or nurse practitioners, so they have some healthcare access, so we got to take that into account. They have the means and the literacy to receive and take long-term controller medications. They're being seen in academic medical centers. We recruited from asthma clinics, pulmonary clinics, and general pediatric clinics. So there is generalizability there, but let's be fair, these are at academic medical centers, albeit in metropolitan areas. It's in the Southeast, that may be different, and in Cincinnati, so that may be a little bit different than in other places in the country. But I agree with you. It's predicated on individuals who have access to healthcare, are healthcare literate, who can participate in a clinical trial and are willing to. So in as much as a clinical trial population is ever indicative of the group that we're trying to provide healthcare benefits to, I think it is reflective. I'm very proud of the fact that we have only about 54% of the population were considered white only. So I do think we have broader representation than some other studies previously. It's never going to be perfect. So I think if one were to want to redo or add to this study, trying to do it in a little bit more of a pragmatic manner, and doing it outside of a controlled, randomized clinical trial might be important to get those extra safety data. But I am proud of the diversity that we have, at least in certain demographics, even though obviously they're an enriched population for clinical trial participants. A lot of words to say, you're totally right, but I'm still going to stick to my statement that I think it's a pretty good diverse population.
And Buddy, it certainly wasn't meant as a criticism. It was just highlighting that that there might be challenges, and just goes to show the value of actually getting good asthma care and how critical that is to asthma control.
I agree. And John, I would maybe just add that, this is where those previous studies that Matt rightly said had their own limitations. But these previous studies, either in large linked databases or the data from the UK where access looks a little different, I think the fact that we're all in the same direction, suggesting that LAIV4 is not associated with asthma exacerbations in this age group, I think that should give us a lot of confidence as we reassess the necessity for that precaution.
Thank you. Are there any additional questions for Dr. Creech or other discussion? Okay. Well, if not, I will turn the podium back over to Dr. Groskopf.
Okay, so the last meeting in October, we had an update from Dr. Rebecca Condor of Influenza B Yamagata surveillance, and we wanted to just come back and touch base on where things are with that now. Next slide. So quadrivalent influenza vaccines, the first one was approved in 2012, but they weren't released into the market until the 2013-14 season. And the idea was to provide broader coverage of influenza B viruses. Up until the late 1970s, the number of viruses in influenza vaccines varied from year to year. There was a lot, I wouldn't say a lot, but there was variability in the formulation from year to year. Starting with about the 78-79 season, we have consistent seasonal vaccination available with trivalents, with an AH1 and AH3N2 and a 1B virus. During the 80s, there was this appreciation that there were developed two lineages of influenza B viruses, for research after that, evidence suggested that there was not optimal cross-immunity between those two lineages. There was only one B lineage in the vaccine, so it had to be selected, and then you might not have, several months later when the influenza season started, you might not have a B virus of the same lineage. So that's just a little background on the B viruses. Again, the quadrivalents became available in the market in 13-14. They contain, instead of one B virus, two B viruses, one from each lineage. And after the 13-14 season, there was this gradual sort of phase-in of them. Some manufacturers went from one season to the next trivalent to quadrivalent. Some phased them in within their brand over time. But we had transitioned to the quadrivalents complete by the 2021-22 season. Really, it was largely complete the season before that in 2020-21. There was only one lot of one trivalent released that season, but there was still a little bit out there. So we've had now a couple of seasons with only quadrivalent vaccines. We have also had, as we discussed, and Dr. Condor told you at the last meeting, no confirmed influenza B Yamagata viruses, at least not naturally occurring ones, in global surveillance since March 2020. The LAIV does contain B Yamagata, so it's conceivable that you could see that in surveillance, but there have been no wild detections of naturally occurring B Yamagata viruses in global surveillance since March 2020. At around the time of the last presentation, there were a couple of meetings that were relevant to that topic. The selection of viruses for the flu vaccine composition is largely the product of 4 meetings. Twice a year, the WHO meets to discuss the Southern Hemisphere viruses. Twice a year, FDA VRBPAC for the Northern Hemisphere. WHO usually meets Southern Hemisphere late October, early September, late September, early October, then again in February for the Northern Hemisphere. FDA's meetings usually follow shortly after, about a week later. At the discussions of WHO and FDA for the Southern Hemisphere in the fall, both WHO and FDA had come away with a recommendation that coverage of influenza B Yamagata was no longer warranted and that should be removed from vaccines as soon as feasible. Since then, WHO has met for their Northern Hemisphere consultation, and they have made recommendations for the Northern Hemisphere for 24-25. And those recommendations do include a fourth virus. They include a second B for those countries that are going to elect to use a quadrivalent vaccine or market a quadrivalent vaccine. However, WHO is not regulatory, and they make these recommendations, of course, for a large number of countries in the Northern Hemisphere. Decisions regarding the composition are made by individual national regulatory authorities. So for us, the FDA, and FDA is set to discuss composition of the 24-25 US vaccines on March 5th, next week. So that is the current status. And the links there are the links to the recent WHO meetings, the FDA meeting for Southern Hemisphere, and then the last one is the announcement for the March 5th meeting to discuss the U.S. vaccine composition for next season. Thank you.
Any questions or comments for Dr. Grosskopf? Dr. Lair.
Actually, it's a question for Dr. Kozlov. If one of the manufacturers wants to take out a vaccine strain, do they just go back to an old trivalent approval, or how does that whole process work?
I think it's on a case-by-case basis, so it depends on whether the manufacturer revoked their license for the trivalent or whether or not they put it in discontinuation. So kind of reactivating that license really kind of depends on what the context was in terms of where they left the trivalent. And in some cases, manufacturers have a current trivalent vaccine approval in this country. So on a case-by-case basis, but there's a pathway for each one of those.
Okay, thank you.
There's a question from Ms. Coyle.
Well, I unfortunately don't have a question, but I appreciate the opportunity to bring up the same issue as I noted before with COVID. So this actually presents a really unique situation that we haven't had before, where we've had a vaccine configuration that we may need to go back to. So for those of you that use electronic health record systems or IIS, the CVX codes have been inactivated because they just haven't been seen or we haven't used them in the last several seasons. So for the upcoming decisions that will be made, particularly for manufacturers that'll be moving to that trivalent as soon as perhaps this year, I think it's going to be really important to have the conversations as soon as possible to talk about hopefully just reactivating the old codes and maybe not trying to come up with new codes because that will make things a little more seamless. But just thinking like long term, we have a relatively short period of time between now and the next influenza season, and making sure that we get the codes right for billing and all the other purposes that come along with that are really important to be thinking about now. So just appreciate the opportunity to make this comment. Thank you.
Thank you. Dr. Beigel is, okay. Any other questions or comments? Okay, so thanks very much to the presenters. It was great seeing all of those data. Thank you to the Influenza Work Group, and we will take a break until 3:45 p.m. So we'll reconvene in about 12 minutes. Thank you.